Mr. Julian Stevens from the United Kingdom will now share his amazing video entitled Intrastromal Femtosecond Laser Correction of Astigmatism.
In the general population, 10% of eyes have 1 diopter or more of astigmatism, but in those undergoing cataract and refractive lens surgery, 46% of eyes have more than 1 diopter, with 36% having between 1 and 2 diopters. The correction of astigmatism is important for about half of patients in order to have the best possible unaided vision after surgery. Sir Isaac Newton described astigmatism in Lectiones Opticae in 1669, noting that oblique incident rays on a refracting surface have 2 principal centres of radiation. He also found there is a circle of least confusion at the midpoint between the 2 foci. In 1825, Sir George Airy coined the term astigmatism, which was suggested by Dr. William Whewell, the Master of Trinity College, Cambridge. In 1867, von Helmholtz developed keratometry, and it was only 2 years later that Snellen published his thesis on correcting astigmatism by correcting incisions over the steep meridian of the cornea. In 1894, Bates in New York treated 2 eyes, taping strips of plaster to mark the steep meridian of corneal astigmatism, and was the first to create non-perforating incisions, noting no aqueous egress. A decade later, in the early 20th century, Lanz published his thesis, but relaxing incisions fell from popularity, and it was the development of intraocular lenses in the second half of the 20th century when keratotomy underwent a revival. This was especially so with the advent of phacoemulsification, with importance being placed upon the best possible unaided vision. Better nomograms were developed, though individual customization was required to take into account each surgeon's technique. Even with this, there is relatively poor predictability, and manual incisions reduce rather than eliminate astigmatism. Manual surgery has the following limitations: imprecision, irregular incision depth, difficulty with arc centration, difficulty with arc angle alignment, perforation, wound gape, corneal epithelial loss and recurrent erosion. There is also infection risk. The advent of the femtosecond laser, allowing precise planning and placement of arcs, corrected many of the limitations of manual incisions. However, there is still the possibility of wound gape and late dehiscence with cylinder arcs that extend to the surface. The ideal is to place the arcuate cylinders within the cornea rather than extending to the surface. In early 2003, Dr. Frieda Lossel, then of 2010 Perfect Vision in Germany, and myself proposed creating femtosecond laser intrastromal arcuate cylinders within the corneal stroma, extending from 80% to 20% corneal depth at an 8 mm diameter. After this, we then used the 2010 Perfect Vision Femtech femtosecond laser system to perform intrastromal arcs without opening to the surface for astigmatic correction. With the introduction of femtosecond lasers for cataract surgery, these intrastromal arcs are now placed under OCT control with precision depth, diameter, and angle alignment. At the end of the capsulotomy and lens fragmentation procedure, the arcs are placed within the cornea, trapping the gas created. It takes 6 seconds to perform, with the system programmed to create cylinders between 80% to 20% depth. The energy is deliberately turned up when creating these intrastromal arcs, as this intentionally creates excess gas. This gas separates the sides of the arc cylinders so ensuring there is an arc gape and an astigmatic effect. The gas dissipates within 90 minutes, and the refractive effect is immediate. High-resolution OCT scanning reveals a spreading of the walls of the intrastromal cylinder, so adding to the effective corneal arc length 90 degrees to the meridian of the arc, exactly like manual AK or LRI. In order to improve on the previous nomogram developed using the 2010 Perfect Vision system and Intralaser, a new nomogram was created for the Catalyst Femtosecond laser. In early 2013, regression analysis revealed there was an overall undercorrection, so a second nomogram was then created in mid-2013, and following this a third nomogram. Each version created a mean vector astigmatic effect closer to the intended target. This nomogram is freely available online at www.femtoemulsification.com. The femtosecond laser intrastromal AK is effective for cylinders between 0.75 to 2.5 diopters of cylinder. Regression analysis was performed, and corneal biomechanics was found to have a profound effect on outcome. The intrastromal AK effectivity is not related to central corneal curvature nor central pachymetry. As a vision provider, become an insider.